coming back with hopefully the technical difficulties being resolved. And just thank you also for the patience that everybody came back for the whole week to attend these lectures. And we'll continue next week with a structural on Monday and some vascular disease on Wednesday. And we'll finish next Friday with wrapping it up with some kind of a panel discussion. So without any further delay, Dr. Mikias, take it over, please.
Okay, so I'm gonna start again by sort of trying to get a little bit information from you guys. So how many people or how many of you guys try to do a bedside ultrasound when evaluating a patient? Bedside echocardiogram, that is.
No, probably not, I think.
Okay.
Not even in the ICU? How about in the ICU? Do you have a chance to do bedside echoes? Okay, I think the answer is no.
Okay, how many of you guys have a standardized, fully functioning echocardiogram machine in your hospitals?
Now you have to define what is fully functional.
Well, let us say, you may not know this, but an echocardiogram machine that is able to do Doppler, that is able to do 2D imaging, color, and possibly 3D, but 3D is not a requirement, but 2D and Doppler echo.
So we're talking about first the machine availability. So can you answer if there is an echocardiography testing in your hospital? You have an echo, there's a yes, one.
Okay, one yes.
This is the question, do you have an echocardiography? So that's Gondar and I think Addis.
Okay.
Yeah, okay, so there is echo, but that fully functional, we're throwing everybody off a little bit, I think. Okay, what's the next question?
So I'm surprised that none of you are actually doing bedside ultrasound, at least in the ICU. I was at Blackline a few months back, and I was impressed by the skill sets of some of the internal medicine physicians, actually. They were able to diagnose LV thrombus, at least get some of the basic views in place. So what I try to do in this presentation, I mean, depending on how much exposure you have had to echocardiography, it might be of some use to you, or if you haven't had any echocardiographic experience, it might be too much. So just sit back and relax, and whatever you get out of it is what you get out of it. I have tried to incorporate some clinical cases so that it makes our discussion a little bit more interesting, okay? So let me show you this. So echocardiography, I think it's the future of medicine. It's being used in several places that we have not used it in the past. It is a very, very important tool for evaluating patients when they present to the hospital in the emergency room with critical vital signs, in the ICU, both for diagnoses and critical care management. Even in the COVID era, for example, there is a very large, or not a very large, but a fair subset of patients that end up having cardiomyopathy as a complication of COVID. And many of these ultrasounds are being done by the intensivists in terms of assessing their LV function or other complications that they might have. And in addition to that, I think the stakes are even higher when you come to a country like Ethiopia, because there is a very, very large subset of patients who end up having rheumatic heart disease. And you can't send every one of these patients to a capital city or to a major city to get echocardiography. I have seen the labs at Black Lion were actually very, very overwhelmed. And I think some level of competency by primary care physicians to at least differentiate between what's bad and what can wait is of importance. And you know, it's something that requires a regimented training program. I did cardiology fellowship for 3 years, and I did an extra year of echocardiography, and I still have a lot to learn. I mean, it's a very, very, very vast field that is very rich with knowledge and can allow you to assess a patient in ways that we have not been able to with just, for example, a stethoscope, right? So disclaimer, I have no financial interest to any echocardiography machine producing company or in one form or another. And these are the types of echocardiography machines that are available. So for example, the one that you see on the left side is what we call a GE Vivid E9. This is the kind of machine that we have in our office and actually at the same time in Black Lion, which I was very surprised. I mean, they have the latest equipment. It can basically do anything and everything from transthoracic echocardiogram. If you have the right probe, you can do transesophageal echocardiogram. What a transesophageal echocardiogram is basically you use a probe and basically do something like an endoscopy. But since the heart is behind the esophagus, you can get very close-up views of the heart that you would not otherwise see with a transthoracic echocardiogram. Its resolution is incredible. And you can basically diagnose illnesses such as endocarditis, structural heart defects, assess valvular disease in a much better way than you would not have to. And also very helpful when you have post-operative patients from cardiac surgery. The one that you see here in the middle is actually what I thought many of you might have had. And if you recognize it, please let me know. It's called a Sonosite machine. It is a very simplified ultrasound machine that does both vascular, abdominal, and cardiac. And its resolution is not great. You don't get very sophisticated Doppler analysis, but it gives you an idea. And a lot of the ICU cares or the ICU centers have it. And I think some of the centers in Ethiopia also have it. But this gives you an idea of where echocardiography is heading to. This is basically a handheld echo machine, and it does really, really well. Okay, what you do is you buy this probe. The last time I checked, it costs about between $5,000 and $8,000, and you hook it up to your tablet. And it doesn't do Doppler, but it does 2D echocardiography and color echocardiography, and its resolution is great. So for initial analysis of a patient, without having to transport them to a different unit or to a different city in our case, it could be very, very useful. Okay, so the other resource that I wanted to introduce you to is the American Society of Echo website. I'll just navigate it with you a little bit to see if the website comes up. I am a member and I have a login and password. So if anyone feels the urge that they want to explore more, I can share it privately. So a couple of areas that I wanted to point out to you guys is what's called, for example, the guidelines, right? Guidelines, very important stuff. So you can search it by topic, you can, in different ways that you can organize it, but let me show you some of the things that they have, right? So, for example, assessment of structure and function.
So we are not probably seeing what you're seeing, Mikhail, just so you know. We have still your slides up because that's what you have shared.
Okay, let me see.
You have to go back and forth from your screen.
How about now?
Yes, now good.
Okay, so this is the website, right? American Society of Echo websites. It has several resources, some of them free, some of them not. I have a login that I can share with you. But the one thing that I wanted to point out to you guys is the guidelines. Obviously, some of them are a little bit more complicated for an internal medicine user. For example, an interesting one to me is guidelines for the use of echocardiography and evaluation of a patient for a cardiac source of embolism. So we see a lot of patients with stroke. Who should get an echo and who should not get an echo? What does a certain finding mean? If you go back to some of the basic ones from 2002 about Doppler quantification recommendations, for example, a lot of them are about valvular disease, how to assess mitral regurgitation, how to assess mitral stenosis. So, and they have a lot of free lectures actually. So, okay. So let me go back to my slides, right? Okay, why don't I see? Do you see my slides?
Yeah, just put it on presentation mode.
Okay. So this is actually a patient who was initially treated in Ethiopia. I know one of you guys had asked about what to do for a patient with anterior wall MI and anticoagulation. So I have thought quite a lot about it actually. So I wanted to bring this case so that we can sort of further elaborate on our discussions. So a 67-year-old man came to our hospital. He was initially managed for an anterior wall MI while he was in Ethiopia. And he was actually treated with aspirin and warfarin. And he had presented here to our emergency room after he had presented sudden onset substernal chest pain, and his EKG showed sinus rhythm with poor R wave progression and some non-specific SCT changes. We tested his cardiac enzymes 3 times to see if he was having acute MI, and they were negative. And a left heart catheterization showed a 100% mid-LAD occlusion. What should I do? Does anyone have an opinion? So he had an MI in Ethiopia several months back. He was treated with anticoagulation and aspirin in terms of his antiplatelet and his anticoagulation. And he came here and got a cardiac catheterization, and LAD is completely occluded. Should I open it or not? Or if anyone has a sophisticated idea, I'm willing to hear it.
So he's having chest pains, you say?
So he came in with sudden onset chest pain, but after a while, the chest pain is resolved. He was living about his life without major symptoms of angina. Somebody said stent, okay. I like it when somebody sticks out their neck. Okay.
So how about the other blood vessels? How are they?
The rest of the blood vessels have about 10 to 20% disease, otherwise completely patent. His vital signs are within normal limits, no other abnormalities. So he's chest pain free. He told you that he has been doing well until he came to the US. It's questionable whether he truly had chest pain or not to begin with, because sometimes people just come to our emergency room for care. No, ብቻም ሳይሆን, his LAD is 100% occluded, and should I open it or not? So the main point is, there is, in cardiovascular medicine, when something is 100% occluded, it's never a straightforward decision to open it up. So especially with coronary disease, things that are 100% occlusion, the myocardium distal to it is probably dead. So if you open it up, there isn't much that you get. And on top of that, the complete occlusions are usually very calcified, technically very challenging to open. So in the past, we used to open chronic total occlusions all the time, but not anymore, okay? So we said, okay, he's having some symptoms. Let's see if there is some viable myocardium. And if there is some viable myocardium, we'll try to decide to open up the LAD, but if there is no viable myocardium, we will just leave it alone. The way we look for viable myocardium here in the US, there are two options. One is a cardiac MRI. The other option is a thallium scan, a nuclear medicine scan. So he got a cardiac MRI, and okay, so let me just move it here. So it says transmural myocardial infarction noted in the left anterior descending artery distributions involving all apical segments of the left ventricle as well as the mid-anterior septum. Okay, and it says these segments are not viable. So the apical segments and the mid-anterior septum is not viable. It says all the other segments of the left anterior descending artery distribution, including the basal to mid-anterior wall basal segments, are completely viable. And the other coronary distributions look fine. And they found an apical thrombus, okay? And I'll tell you a little bit about the advantage of cardiac MRI, especially for trying to look for apical thrombuses. And he had an EF of about 46%, and the RV looked fine. So what they're telling you is the apex is dead. He has an apical LV thrombus, and some of the anterior wall is fine. The other anterior wall, the other parts of the anterior wall are dead. So we went ahead and opened the LAD because he has some viable myocardium in the area that would have been supplied by the mid LAD, okay? So let me exit this. Okay, so we opened up the LAD with a drug-eluting stent. We put them on Plavix and warfarin, we did an echocardiogram when he came to my visit. And let me share that echo with you. Okay, how do you get out of this? Okay.
So you minimize, stop sharing, and then select again share and
Yep.
go to the screen you want.
I think you see it now, right?
Yes.
Okay. Okay, so, you know, I'm gonna go through the echo images, giving you some general overview of what an echo is about. So basically you have the transducer that's sitting at the person's chest in different positions, and the closest structure that you see to the probe from the parasternal long axis view is the right ventricle. This is the left ventricle, and this is, so the first thing that you need to do is you need to increase your depth so that you can see all the structures behind the heart. So if you had a pleural effusion, a left pleural effusion, for example, it would show up here, right? So again, we decrease our depth so that we can increase our view of the left ventricle, which is our main focus here. This is the right ventricle. It's contracting fine, okay? So this is the aorta, this is the mitral valve, this is the left ventricle. This is what we call the posterior wall. This is the anterior septum. And I mean, I might try to convince you that you can see that this is kind of thickening as well as it should, but the anterior septum looks a little bit thinned out to me. and the contractility of the anterior septum, which is actually an area that is supplied by the LAD, looks a little bit diminished. This is what we call color images, okay? So what we use color images for is to estimate regurgitant volumes. So the mitral valve should only spill a little bit back into the left atrium. If there is a whole lot of blood coming back to the left atrium, that's a lot of mitral regurgitation. And the same thing for the aorta. Okay, let me go through some of the images. So other things that we use an echocardiography is to estimate chamber sizes and size of the aorta. So if you have an aortic aneurysm, you can see that you can estimate a little bit parts of the aorta. You can't see the whole aorta, obviously. So in this case, the size of the aortic root looks normal. This is what we call the left ventricular outflow tract measurement. This is the left atrium measurement. And other things that we do is also estimate the size of the left ventricle, right? So there are normal sizes for both the walls and the chamber size. People who have had ischemic heart disease. So for example, you look at an x-ray and say, oh, cardiomegaly, right? So also standard sizes for a heart when you do a 2D echocardiogram. So let me just show you a few more other representative images and tell you why I brought this up. This is the tricuspid valve. There is a little bit of spilling here. This is what we call Doppler analysis. So basically what a Doppler used for is for estimating the velocity of blood that is flowing in a certain direction. And by using that, you can estimate gradients between chambers. And that is, for example, the main tool that we have when we try to assess aortic stenosis. This is what we call a short axis view. It cuts the ventricle like a donut, okay? This is what we call an M mode. This is what an echocardiography used to be about 40, 50 years ago. There was no 2D, so there was no moving image. So from this, people used to diagnose mitral stenosis from just strips of pictures like this. So this is what we look at the aortic valve in a short axis view. You can see that the valve over here is opening fine. I'll show you a case of aortic stenosis. So let me go to the apical views, okay? Okay, so this is what we call an apical view, okay? So from here, there's a couple of things that I wanted to point out to you. So basically, we go to the mid-axillary line a little bit further down from the nipple to get several views of the heart, and the probe is closest to the apex of the heart. Because of that, there's a whole lot of limitations to diagnose LV thrombus from echocardiography. You have a lot of shadowing around the apex, and it's very easy to foreshorten the LV apex. So if you don't see an LV thrombus in apical view, it doesn't mean that it doesn't exist. I mean, there are several ways that you can pick it up using, for example, echo contrast materials. And I feel like many of what I'm talking about may be something that you guys are not aware of because many of you are not even doing the bedside ultrasound machines at your hospital. But basically, you know, this is the right ventricle, this is the left ventricle. And over here, I don't see any LV apical thrombus here, right? And the time difference between this echocardiography and the cardiac MRI is within a couple of weeks. So I know that there is an LV thrombus, I just cannot pick it up because I know the MRI has picked it up, okay? So it's there, but I can't see it. Okay, so other views that we have. This is what we call tissue Doppler. These are the images that we use to analyze diastolic function. Okay, so let me show you a couple more. As you can see, it's a very detailed study. We have like almost 69 images. So the other view that I wanted to show you is the subcostal view, okay? So this is actually a view that you should practice while you are in the hospital if you have any ultrasound machine. What we try to do is we go under the subxiphoid to look at the heart upwards. And by doing that, there's a couple of important structures that you are trying to look for. One of them is the IVC. And the IVC size basically determines whether a person is feeling pressure to the right atrium is high or not. So for example, one of the common things that I used to use it for when I was a resident is to see if a person has had adequate fluid resuscitation when they come in with sepsis, right? So with sepsis, antibiotics, fluids. But sometimes a person continues to be hypotensive and you are not sure if it is because you should give them more fluids or if it is because it's a vasodilatory shock that they would need vasopressors. So you can look at the IVC here, which is very small, collapsible. So the person's right atrial filling pressure is fairly low, which is how you want it to be, okay? When he's coming for an outpatient visit. In the ICU, that might be a different scenario. Okay, so and I think the person again tried to look for more images to see if they can bring up the LV thrombus, but I don't see it. Okay, so let me share my. Okay, so basically, then I send him back to Ethiopia and he gets an echocardiogram again over there and they did not see any thrombus and they asked him to discontinue warfarin. So what would you guys do? Is that the right approach? Okay, so let me just rephrase the question again. Okay, so he had an anterior wall MI, his apex was dead, so was not going to recover. Okay, I think some background noise, I'm not sure. Can somebody mute their mic?
Sorry, I think it was mine, so I did.
Okay,
so the question is, you know, he has now no more thrombus in his left ventricle now, at least from the imaging they got, and he asks now if he can get off warfarin. Is that right?
Yes.
So anybody agrees with taking him off the warfarin or not? That's the question here. Somebody said it will continue because of the stent.
Okay.
We should have a medical summary from you before I discontinue. So I think you're being assigned as the primary cardiologist for the patient. Okay, who's next?
I love it. I love it. Discontinue. Okay. Okay, so I have discontinue. I said, okay, so let me ask. So Takalling, a strong point. One thing I would say is if you have a stent inside you, what you need is not an anticoagulant. The indication is for antiplatelet. So antiplatelets with aspirin and a P2Y12 inhibitor for at least a year. So so anticoagulation does not, I mean, a stent does not necessitate anticoagulation. Okay, so somebody said I will continue because of anterior infarct. Okay, dead myocardium. Okay, thanks. Okay, so they stopped it, and I didn't think it was the right thing to do. Okay, and I'll tell you why. So the whole reason why a person forms a clot in the apex is because the apex is akinetic or hypokinetic, okay? So unless you have done something to the main reason why a person is forming blood clots, which is that if you are able to improve the apical segment contractility, that is fine, you can stop it. But if you have not changed the apical segment contractility, which is the main reason to begin with why he formed a blood clot, then to me, after a person forms blood clot and you give him warfarin and the clot resolves, I don't think it should be irrational to discontinue it because he's gonna go right back and form it, okay? So, and I'll tell you this, there is no exact guideline that tells you what to do, okay? A lot of what I have read says after 3 months, it's up to you, basically, okay? So they went ahead and stopped his warfarin. And he comes to me for a follow-up after a year. And he says, yeah, they looked at my apex, they didn't see a blood clot, so they asked me to stop it. And I said, no, you can't do that. And the person obviously was not happy with me, though he was willing to listen to what I have to say. You know, asking a fellow Habeshan to take one more medicine is a big hassle, especially warfarin, and I understand that. Because checking it in Ethiopia it's very challenging. So I said, okay, why don't I do this? I told them, I will send you for a cardiac MRI again and see what we see. And depending on what we see, if the apex contractility is better or if I don't see anything, then you can stop it. This is what the read came back as, okay? So it says a year after, okay, somewhere about at 9 months, they stopped his warfarin. It says apical left ventricular thrombus is noted, okay? And then it says, then that's the stuff that worried me came after. It says, previously seen LV apical thrombus is present on current study with changes in appearance. Previously, there was an apically layered thrombus measuring 15 millimeters in diameter and 9 millimeter in thickness, okay? The layered component appears smaller and thinner. However, there is a small, separate and round appearing thrombus at the same site in the LV apex, which measures about 7 millimeter in diameter and is best seen on 4-chamber images. So in the past, what he had is a layered thrombus. So basically, you know, a thrombus over time hardens. There is a lot of fibrous tissue that develops. There is probably a fibrous cap. So chronic thrombus doesn't really bother me, but there is some evolution of the thrombus, okay? There is one that is separating on the side, probably ready to break off. I don't know. So I showed him this and he finally agreed that he resumes warfarin. So, and about 4 weeks after, I got a call from an outside hospital because he had presented to the hospital with shortness of breath and severe anemia. They did a workup for bleeding. It was negative. So finally, he was very resistant to it. And I said, okay, we'll just discontinue the warfarin. I hope he does okay. But what I wanted to tell you is, so it's not an exact science what you do after it. In my opinion, if apical LV contractility has not improved, if a person has already formed LV thrombus in the past, I don't stop it. To be honest, I have a lot more options in terms of other medications that I can use, even though off-label, such as apixaban, or that checking warfarin is not as big of a hassle for me as it is for you guys. So maybe the equation shifts a little bit when you are practicing in Ethiopia. And the other thing I wanted to tell you is, so the guidelines state that giving a person with anterior wall MI anticoagulation is a class 2B recommendation. So it's kind of maybe. But remember, the type of patients that we see here in the US is completely different from the patients that you see over in Ethiopia. Because in the US, almost everyone gets revascularized, okay? So the evolution of acute myocardial infarction in the US is completely different from the majority of non-revascularized patients that you guys are taking care of over there. So exactly extrapolating what the guidelines say over here to practice in Ethiopia may not be correct. So you should watch out for, you know, how the pathology changed from the Western world to a third world country. And you know, if I was practicing in Ethiopia, I agree with you. I would give anticoagulation for all patients with anterior wall MI, probably coupled with some sort of an antiplatelet such as Plavix, and after 3 months, probably discontinue it. But for patients who are who end up forming LV thrombus and are able to take warfarin and check their warfarin, I would probably continue with lifeline. So yes, I'm not, well, I hope that that was a useful discussion. Any questions about that?
So if you have some more case or so to do, why don't we just finish that and then go to questions?
Okay.
Otherwise, it will disrupt the flow.
Okay. So I think we have
maybe one more case if you have.
Yes. So let me show you another. This one is good. Okay. So this is a patient that I saw actually a couple of weeks ago. So a 62 years old man with progressive lower extremity edema and shortness of breath that he reported during an e-visit. So basically during COVID now, we don't see everyone in the office. So this was actually my colleague who saw him over a video visit, and he told him that he was having some leg swelling, shortness of breath, his belly was getting distended. And the main thing that you need to know was he had coronary disease and CABG about 3 months ago. He had Lima to LAD, Savannah's pain graft to the RCA and the circumflex proximally. So what is your differential for this? Any differential? What's going on? Try something. Okay, I'll tell you what's there. So, you know, the things that were coming to our head is, you know, his LV function was normal right before his bypass graft. Maybe one of the grafts failed and he's developing some sort of a cardiomyopathy and heart failure. It could be because, you know, he's 62. He might have diastolic dysfunction. He's eating a lot of salt while he's at home and he's getting, you know, volume overload. And the other thing is pericardial effusion. So we brought him into the office for an echo. When I saw the echo, this is what I saw. Okay. Okay, good. Do you see the images? Yes, no?
Yes, we can see.
Okay, good. So this is basically what pericardial effusion would look like. So remember, you can have fluid around the heart, but if it is beyond the pericardium, that is a pleural effusion. And the way you differentiate that is if it is beyond this very highly reflective structure, which is the pericardium, that's basically the main point. And the other thing is the structure that you see here is the descending aorta. So pericardial effusion is almost always above the aorta, and if it is below the aorta, that is pleural effusion, right? So, I mean, there are some impressive things about this echocardiogram. First of all, you can see that the right ventricle is almost squished. I mean, it's supposed to be at least 2/3 of the ventricular size, and you can see that it's like a grape. How many centimeters do you think this fluid is? Okay, I'll show you images. Okay, so this is the left ventricle, the aorta, the mitral valve. The heart is basically swimming. The left ventricle size is small, partly because of compression and low preload because of the pericardial effusion. So there are clinical criteria of tamponade and echocardiography criteria for tamponade. So the four things that we look for in terms of echocardiography and tamponade is: one, collapse of the right ventricle during diastole, or number two, collapse of the right atrium during diastole. Number three is exaggerated respiratory variation in the mitral and tricuspid inflows. And the number four is dilated IVC, okay? So if you look at this, this is how you track the different cycles of the cardiovascular cycle. So this is the QRS, which is the systole. This is the P wave. So diastole is somewhere around here, right before the QRS begins. And you can see that, you know, from here, I can slow the images and show you, but the right ventricle does not really fully expand during the time that it should expand, which is diastole, right? During diastole, the ventricles fill. So it kind of starts to expand, but you can see that there is some sort of a jiggling thing that it does, which is basically a sign of a collapse during the diastolic period. And let me show you a few more images. So the fluid is about 5 centimeters, by the way. This is a scale. So this is 10 to 20, right? So this is about 5. So this is what it would measure. I can find the specific frame and show you, but for the sake of time, I think I will not. So here you go. So 5.8 centimeters in the posterior direction. And let me show you a couple more features. Again, this is the apical view. So this is what we call exaggerated respiratory variation and mitral inflow. So remember, this basically, these two spikes correspond with an E wave and an A wave. The E wave is the passive filling of the left ventricle, and the A wave is the atrial contractility towards the end of diastole. And you can see that basically from the highest to the lowest is more than 25%, which is the echocardiography criteria for diagnosing exaggerated respiratory variation. This is the respirometer. So breathing in, breathing out, breathing in, breathing out, and this is the EKG. So that is the second feature. And the last one that I will show you is the IVC size. So in this case, it's about 2 centimeters, not the biggest IVC that I have seen, but there's supposed to be variation in the IVC size during respiration, which this person doesn't have. So I sent him to the cardiac catheterization lab immediately. We drained about 1.4 cc's right away, and another 800 cc's came in another 24 hours. So about 2 liters came out of this person from the pericardial region. And the moment the fluid came out, he said, I feel so much better. His bloating started to get down. His leg swelling started to get down. So he was discharged afterwards after an echo showed no pericardial effusion. So if you, do you guys do pericardiocentesis at your hospital? If you don't, what would you do for this patient? If there was no pericardiocentesis you are able to?
So in other words, if there is no possibility of doing pericardiocentesis, how would you treat this person? Okay.
Yeah.
Any answers? Let's see. Diuresis, steroids.
Okay, diuresis, steroids. Steroids, I agree, but diuretics is not what you want to do. It's very dangerous, actually. So if you come to the hospital with tamponade, the treatment is fluids up until you can take out the fluid, because the problem tamponade causes is that the extra cardiac pressure is higher than the intracardiac pressure. So the heart gets compressed, right? So what you want to do is you want to increase intracardiac pressure. So actually what we do, if we have to wait before a pericardiocentesis is done, we give them fluid. So diuretics is a no-no, okay? So no diuretics. Fluid is what you want to do. And I agree with you. If you have no option, you have to give them high dose prednisone if you're not able to take it out. But the other thing I want to challenge you is, you know, if you have a needle and there's a person about to die, you better give it a shot to take out the fluid, because in a code setting, that's what we do, okay? So you don't necessarily have to see the person die before this happens, because, you know, if you do a code and you have a bedside ultrasound and short pericardial effusion, you just stick a needle in that. So, and it's not a very complicated procedure. You can read about it. There are obviously some precautions that you need to do to make sure that you don't injure the lungs or the liver. You know, this is how competency is built.
So, Mikias, I have a question for you. I mean, there is a clinical scenario where you can have a post-CABG pericarditis, right? Some inflammatory. So, which seems like this person probably fits that picture, or is he out of that window? It's something that happens relatively early, doesn't it?
It does relatively early. And I mean, if you have pericarditis, in my opinion, you should have some chest pain, and also your inflammatory markers should be elevated. But I'll be very honest with you. A lot of these patients actually get out on colchicine because it's almost a case of why not? Because the medication is fairly benign. You know, they would report sometimes chest pain that is related to the incisional pain. Would really not be able to figure it out. So we just say, okay, take colchicine for 3 months and we'll see you then.
So the other question is, you know, most of these patients at CABG will have also, you know, a pericardial window right there. I mean, it's, you know, it's very, I'm kind of puzzled how much fluid was collected. This must have been closed really nicely. Is that what happened?
I don't think they do pericardiotomy prophylactically. There's some healing of the pericardium that happens. And remember, you know, pericardiotomy, even for patients with pericardial effusion, doesn't really work that well.
So if it's connected to the pleural cavity, you know, it will drain. So that's it. Any, so thanks. Are you done with the presentation? Can we open up for questions, or it can continue, right? There is no end. So
I can show you a couple of things, if okay with you. And there's one important point that I want to make.
Okay.
It takes probably 5 minutes. Okay. Okay. Okay, so it takes probably 5 minutes to talk about this. I thought this was an important thing. So I'm gonna give you a hypothetical scenario and you're gonna tell me what we need to do next, okay? So a 55-year-old man, he has a history of hypertension. He comes to your office with intermittent chest pain, which he describes as left-sided, dull, non-radiating, 5 out of 10 intensity, and it happens mostly when he's sitting at his desk at work. He tells you that he's active and runs 5 kilometers every morning prior to work. And you ask him, you know, how do you feel after running? Do you have any chest pain? He says, no, I actually feel really great after I run, and I have no chest pain after exercising. So in this man, before I forget, let me address one question. Do we give steroids for patients in CAD? There is no contraindication to give a patient with CAD any steroids. Steroids are in general both a good and a bad medicine. So before, I always think twice because of the side effects that they have, but CAD in itself is not a contraindication. Okay, so in this specific scenario, what should I do? an exercise treadmill stress test will add significant diagnostic utility, will not add significant diagnostic utility. So I'm hoping that everyone will participate. So I gave you the scenario. He has chest pain, he runs, he feels great after running. So, you know, he's 55, he has hypertension, he's saying that he has some chest pain. What should I do? So exercise treadmill stress test or no stress test? I need to see a couple answers. Okay, we'll add significant diagnostic utility. Okay. We have to appreciate Adana because he has been an active participant, and I appreciate that. Okay, so 55 man, dog chest pain, exercises, feels fine, stress test, no stress test. I'll give you about 20 seconds. This is a simple choice, guys, A or B. Okay, so in my opinion, I don't think he needs a stress test, and I'll tell you why. Because this guy is basically doing a stress test every morning, okay? And so, you know, I want you to take the idea of a stress test in a very simplistic way. So when we do a stress test, the whole purpose is to bring out symptoms of obstructive coronary disease that would not otherwise be apparent while a person is resting. So in order to do that, we have to find a way of stressing the patient or the heart as it is, which is through either exercise, regadenoson, which is a chemical that you don't have in your office. Yes, Adana has raised this, and I'll let you ask your question. Let me just finish this point and I'll let you ask the question, okay? So regadenoson or dobutamine, okay? And ways of assessing for ischemia could be as simple as symptoms, and you can use EKG, echo, or nuclear imaging, okay? So there's a couple of things that reassure me about this guy, okay? So one, he's able to have an exercise tolerance of about 5 kilometers. He runs every day and he feels great, okay? So a person who has good exercise capacity without having symptoms, even if they have coronary disease, they are in a very favorable category, okay? So there is a difference between a person who tells you that they have chest pain after running 6 kilometers and a person who says that they have chest pain after walking 2 blocks. The person who has symptoms after walking 2 blocks is in a high-risk category because his symptoms come in fairly early during exertion. So even if this guy has coronary disease, then because of his high exercise capacity, in my opinion, he's in a favorable category with a very good prognosis. So he's going to be fine. And the other thing is he does his stress test every morning to begin with. So in a resource-limited setting, where stress tests may not be available right away, or you have to send them to a capital city or some cardiologist and the person has to pay a whole lot of money. In this guy, I don't think I would do it. But there is no exact answer. In my professional opinion, no, but I'm not trying to tell you that those who say that you would do a stress test is significantly wrong. Anyway, okay. So Adana, I'll let you ask your question. Is symptoms only enough? It is not. You are 100% right. So, and that's why I went into the issue of prognosis, right? So, even if this guy has coronary disease, I mean, ultimately my goal when I treat a patient is two, right? One, I want to make them live a healthy life, and two, I want to make them live long. So the fact that he is able to do this much exercise means that his prognosis is good. He's likely not going to die. And two, he has no symptoms. So even if I find it, What am I going to do for her? You're right. Symptoms is not enough, but it's about prognosis and diagnosis. I feel reassured that even if he has it, that his prognosis is fairly good because of his good exercise capacity. And remember, read about the COURAGE trial, right? There is no scenario in cardiovascular history where a stent placed for angina alone and not for acute myocardial infarction ever saves a life. It's all symptom relief. The companies have tried quite a lot, but they have failed. Okay. I think enough confusion for today, right?
Yeah, so let's take a couple of questions before we conclude our session today. It's interesting that you say, you know, echo is going to be the future of medicine, but I thought ultrasound has already taken over, right? That we have it in our offices. You know, you do breast examination in the office, you do, you know, gallbladders right there, and it's like becoming a stethoscope. So I think what you're trying to say is maybe with those portable devices and the probe, you know, we may actually also take a look at so many other structural things, both the heart as well as, you know, the blood vessels, because I think it makes sense to have the offices that have all those kind of equipments. And in fact, we are designing a new hospital here in my city, and the vascular team was discussing about all the things we need in the patient examination room. And one of the things we have asked for is in those rooms to have all those different probes so that we could actually do a complete physical examination by looking at the vessels as well. You know, like almost a screening, you know, it's not like going to be an official report, but I can see that future, actually, what you mentioned earlier. So that said, I just want to also please emphasize and stress, please share Malaku's email that he gave you at the beginning of his, in the chat section. And Malaku, if you can send that again so that they can share with some more of their colleagues for the future lecture series, that would be great. So any questions for Dr. Mikias? Let me see if there's anything that we did not touch or answer from before. I thought understanding acute occlusions of a vessel in acute MI and chronic total occlusion is the key in deciding management plan. I guess that was for your total LAD occlusion that Henok was commenting on. Understanding, is this occlusion acute versus is this occlusion chronic? Probably is what he was getting at, I think. Any comments on that?
So this is definitely a chronic occlusion because he didn't have a positive enzyme test. So if you have an acute middle AD occlusion, you will know when you see the patient, and his enzymes would definitely be positive.
So I know you have touched about the novel anticoagulants earlier, and I think there was a question about that, which I don't find it, but I don't know if you can scroll in your.
Okay.
So in terms of, you know, anticoagulants, I mean, how often do you use these days Coumadin in your practice? Is it out of favor? Is price the issue, insurance coverage, or do you still give Coumadin?
So an interesting question. So first of all, somebody said, would rivaroxaban be an option for apical akinesis patient in anterior wall MI? To be honest, I don't think I would use it in an acute MI setting. But if you have an LV thrombus, we have been using it off-label, and which means that you have to tell the patient, tell them that, you know, it's never really approved for this. We think that's going to work, and you have the advantage of not checking it. so for example, the time that I use warfarin, one, rarely there is an insurance issue. And when there is one, it's actually fairly expensive for the patient. So we go ahead and do that. Two, I mean, we see a few rheumatic heart disease patients now. I'm getting a steady stream of patients actually from Ethiopia. So in those cases, you absolutely have to use it because NOACs are not approved for valvular AFib. But otherwise, I mean, NOACs have taken over. Could use echo to check for myocardial viability. Yes, you can, sir. Yes, you can. You have to have a very good echocardiography laboratory. You can use dobutamine to check for viability based on the response of the myocardium at low and moderate doses. You can use, I think, 5, 10, and 20. And there is variability in contractility from a low dose to a high dose. You are 100% correct. And somebody said, would you please share your password? Okay, I will certainly share my password. I will send it to Mel. I'll actually send you 2 passwords. One is for up-to-date, and the other one is for American Society of Echo. The one thing I would ask is, because they will be tracking as to how many devices this has been logged on. For me, it doesn't matter, but if you could use only 1 station per institution, so that it's not 50, but about 10. But I'll send it to Mel.
I would just please send it to Malako, and then I think we just need to have a person from an institution. Otherwise, it will become a problem.
Yeah, what I would do is I would log out at a station, and everyone who wants to use those resources can do that.
Great. So I appreciate that, and Malako, thank you for helping us again today. And those of you who have email issues, please send your emails. Please invite the other residents on Monday. We'll reconvene with the structural heart disease talk that we did not finish. I think subsequently on Wednesday, we'll go over vascular diseases. I think everybody, both in internal medicine, in cardiology, in surgery, everybody has to know about vascular disease because it's really of epidemic proportions. There is about 200 million vascular patients across the globe. So we'll do that on Wednesday, and Friday is going to be panel. So I just want to say thank you to Dr. Milkias for a very engaging talk again today, and we'll see you next week. Have a great day.
Yes.
Great weekend.
Same to you, everyone.